So my talk is about the use of collagen membrane scaffold. I want to thank first Black and White Manos for this kind invitation. It's always a pleasure to be here. It's a great honor. Okay, this is a disclosure of my conflict of interest. We have seen that problem of glenoid bone loss is still debated, especially regarding the gray zone between the no bone loss situation and the great critical bone loss on the glenoid side or an off-track lesion, as if we consider bipolar condition. New thresholds for glenoid bone loss have been described recently, and probably now 20% that was considered in the past was reduced to 13%, I would say. But what to do exactly in these cases, especially when they're combined with different pathologic findings on the soft tissues? And if we look at recent literature regarding the success of a standard bunker procedure, probably total recurrence rate, if we consider a combination of recurrent dislocations, subluxations, and symptoms of residual instability, it's pretty high, it's approaching 30%. So a recent study on risk factors for recurrence of bunker repair showed that also if you had just two dislocation episodes or a long history, longer than 6 months after first episode, a consistent risk of failure of bunker repair. So according to this information, probably the bunker repair should be recommended also for first-time dislocation. Okay, this is some incendiary assessment, but probably we should rethink about the role of bunker repair, standard bunker repair, and we have to look critically on our experience and literature as well. But if we look at the bone block procedures, whatever you do, Latarjet or simple bone block or Edeni Binet or whatever it is, we see that the use of bone block procedures is associated with a much higher risk of complications, and this is an issue that must be addressed in the future if we want to use this type of procedure. So my opinion that is we should understand the pathology first. So what's really the cause of instability, bony defects or soft tissue defects? And if we look at our shoulder, all the defects should be assessed at the beginning to establish the right treatment protocol. For sure, imaging can provide useful information for soft tissues and for bony defects as well. The CT scan for me is the gold standard to assess, quantify the presence of a bony defect on the glenoid and humeral side. And this because the role or the importance of bipolar defect is crucial to reduce the risk of failure of our procedure, whatever you do. And the glenoid track concept that was completed by Giovanni Di Giacomo with the definition of on-track, off-track concept is probably actually the most used and applied method to quantify the bony defect and its clinical relevance. But unfortunately, reliability of this measure is still rather controversial. And especially off-track lesion as an outcome predictor is still debated. And this because probably we have also some on-track lesions that are still at risk. According to two recent studies, if we have an on-track lesion that still has ethically defined as a peripheral, so more located on the articular side of the humeral head, we probably have a risk of instability, of a residual instability after standard isolated bunker repair. And if we look at the measure that we use to assess on-track, off-track, instead of just a difference between the Hill-Sachs interval and the glenoid track, this author suggests the use of a ratio between these two measures, and when this ratio is higher or equal to 0.7, the risk of recurrence is considerably higher. And that's the reason why Ito and his co-workers paid attention to this kind of lesion and said, even if this is a non-track lesion, take care because probably it's at risk of the redislocation, especially when the medial margin is located between 75 and 100% of the glenoid tract. So the new threshold for bipolar is not on track off track, but 70 to 75% of this Hg ratio. And this is what I do in my current practice. And we look at this retrospectively on a series of patients operated with a non-track lesion by a Bankart repair, standard Bankart repair, and we found that no differences were observed for clinical reported outcomes, but recurrence was higher. I would say not significantly, but probably this sample is underpowered, but 10% versus 0 is something that should be considered. Soft tissues, and this is the main topic. Some studies focused on the role of the labrum and showed that postoperative small labral height is correlated with recurrent instability and poor functional outcomes. And the decrease in labral height at 1 year postoperatively is related to a risk of recurrence and poor clinical outcomes. And this information was confirmed by a more recent study on the effect of labral morphology on the risk of recurrence, and the authors showed that a small labrum morphology at time of surgery is correlated with a higher risk of recurrence. So labrum matters. And that's the reason why we start doing this procedure some years ago. It's a labral augmentation. Indications for this procedure are labrum insufficiency related to a traumatic tear or a condition related to a multidirectional instability, like the technique suggested by Enrico Gervasi some years ago, who suggested this technique for a multidirectional instability with a circumferential augmentation of the labrum, or an inherent glenoid flattening, so to increase deepening of the glenoid cavity to increase the joint surface area. So this is the rationale of the technique. A labrum augmentation can be obtained basically with a collagen scaffold, as I usually do. And the collagen membrane is rolled up, and the final graft is 7 to 8 millimeters in diameter, and it's fixed with some sutures at the two ends to be shuttled into the joint and fixed to the capsule and to the labrum as well. So we first measure the length of the anterior glenoid rim to assess exactly the length of our graft, and then we pass a traction suture. So the first stay suture is passed down to the anterior capsule, and the graft is pulled inside the joint from the anterior superior cannula, and traction sutures are retrieved from the mid-glenoid cannula, and this PDS suture is temporary, is used as a temporary fixation for the graft to the anterior inferior capsule. Then the graft and the capsule are fixed like a standard Bankart repair, so that the procedure doesn't require an additional portal or specific steps to accomplish the Bankart repair. So I use knotless anchors to fix the new labrum, the residual labrum, and the capsule at the same time, and I get a bumper effect, and the capsule is folded just a little bit over the graft to improve synovialization of the graft, to improve healing, to integration into the surrounding vital tissues. And the final result shows a good restoration of glenoid concavity, and a good restoration of the bumper effect of the labrum. Results at 3 years follow-up. We have patients between 3 and 4 years after surgery. This is a series of just isolated anterior instability, traumatic instability. We had one redislocation at 3 years, no intraoperative or postoperative redislocation, and patient-reported outcomes show a significant improvement from baseline conditions. And these are the MRI performed 6 months after surgery. You can see a good integration with the surrounding tissue and a good restoration of the normal profile of the anterior labrum in terms of width and height. Another possible indication is the use of this procedure in case of revision surgery, just limited to cases with no critical bone loss, with a labrum insufficiency gain, and eventually in cases of multidirectional instability, in which capsular ablation were not adequately addressed during the first surgery. An alternative to collagen membrane is the use of autograft, like semitendinosus or two-folded gracilis tendon. As this technique has many advantages. First, in terms of cost, for sure, because it's much less expensive than the collagen scaffold. Is an autograft, so no problems related to donor morbidity, and is useful especially in cases of multidirectional instability, because you have a pretty long scaffold which can be used just all around the glenoid. Allografts is another alternative, especially when you have a poor tissue quality, like in case of collagen disease. Especially in cases like these, allografts are recommended because of poor too elastic tissue of the recipient, and in this case we used to recreate not only the labrum, but we reinforce also the capsule with the tendon grafts, like in Ehlers-Danlos or Marfan disease patients. So in conclusion, key factors for me to achieve a successful procedure is to understand pathology first. Second, and this is my philosophy, try to restore the anatomy at any cost. And when you have a labral insufficiency, consider an augmentation, whatever you want to use. But remember, bone defects matter, but never underestimate soft tissues. Thank you for your attention.